So I'm Dr. Zorba, pastor. I'm going to move around. If you can't hear me, please tell me that you can't hear me in the back. Before I talk, and first of all, I'm going to talk about some of the things I said I was going to talk about, but I'm going to talk about other things that interest me and I think will interest you also. But I want to talk about numbers because it occurred to me. So when I was here, there were like 3 or 4 people. There are now 5 times as many people. So here it is. You hear a number. You're looking at a medical number, and they go 5 times as many people had this disease as didn't have the disease. You need more information to decide what that means. So let me give a perfect example of a patient. So my name is Dr. Zorba, pastor. I write a medical column, as you know, because that's why you're here. I'm on radio, I'm on TV. I'll be on TV on News 3, by the way, at 4:30 this afternoon, discussing barbecue and safety and food safety. So I'll be on TV. That's how you sort of reach people. Radio, TV, podcast, written word, all those different things. That's how you become medically savvy. And the educated patient receives the best care by far. There's lots of data about that. And you're all here to be educated, because otherwise you'd be home watching something on the remote. God knows what it is. Lawrence Welk reruns. He's still on TV. Can you believe it? I found him boring when I was a kid, and I find him boring as an adult, but he's always there. And a 1, and a 2. Really. I read a whole story about him. By the way, he was one of the wealthiest performers ever on television. He made more money than anybody else. So if you go to Wikipedia and you read about Lawrence Welk, you'll realize what a savvy businessman he was. But I'm not here to talk about Lawrence Welk, although I did. But let me talk about numbers for a minute. So I had a patient. I have a hobby practice now. I work 3 to 4 days a month at one of our Dean SSM sites. In Oregon, I'll be in Edgerton on Friday. I go to Wanakee. I've been at Southwest, the various sites. And it's really kind of interesting because I really like it. I get a chance to be with other people and see other people. But I work full-time for 45 years. When I started practice, I joined Dr. Kellogg in Dukeshine. Kellogg came there in '53. He had been in World War II and Korea. And Dukeshine had been in World War II. Or rather in Korea. And they were on every other night until I joined them. So they were, quote, dedicated doctors, but their children never saw them because they were, quote, dedicated doctors. They would go into the office all the time. They stayed at home by the phone to answer the phone every other night when they were on call. They didn't believe in pagers or anything else. So they gave a lot of patient care. But one of their kids said to me, "Thank you for joining us. Now my father can finally go to a basketball game." Very interesting. But let me tell you about a patient. I want to talk about numbers that were, these numbers we're talking about. So I had a patient who came in, and educated guy, was a professor at the university, and he had a hernia. And we discussed hernia surgery. He said, "What about a truss?" I don't know if any of you have ever seen a truss. They're kind of disgusting. What they are is you get a hernia. The hernia is a bulge here. And if you don't have the surgery, you wear something to push it in. And basically, it doesn't get washed every day, so it's not clean. And they have metal things that go over here to push it in. And trusses were very important in the 30s and 40s when surgery was not advanced, when you would get infections and stuff. So it was really very common when I first started practice. But he was wearing a truss. He'd been wearing it for a few years, and he was debating about having surgery. I said, "Okay, well, these are the surgeries you have. It's not a robotic surgery, but it's a minimally invasive surgery. It's done through a scope. Used to be, when I started medical practice, men and women were put in the hospital for 5 days on bed rest because they were afraid the incision would break. In fact, that was bad medical care because it caused pulmonary embolism because we put them at bed for 5 days. We didn't understand it because nobody had ever done that. And an outpatient basis was never done that way. But now it's done an outpatient. So he said, "How's it going to be done? Because I want to know before I see the surgeon." I referred him to a surgeon. And I said, "It'll probably be done and you'll have a mesh put in because you're older. You're in your," I think he was like in his early 80s, "and a mesh is better." And he said, "Well, I've heard it has more infection." I said, "Well, let's look at the data." And the amazing thing, of course, about the web, and of course what I have, is I can immediately look at data. I can look at something called UpToDate, which is the standard medical thing that we look at. Basically, it's been updated within 1 year. It's called Up to Date. And you can read when it was updated, you can read who the editors were, and when the last update was. And the last update happened to be 6 months, and it said the mesh is the way to go. The European Society of Surgeons, I then looked somewhere else, they recommend the mesh. The Australians recommend the mesh. The English use the mesh for someone that age, the Americans. But he had heard that it had 50% more infections. I said, well, that's interesting. Maybe let me look that up. So I looked up the data, and he was right. There were 50% more infections. Instead of 1.5% of infections, it was 2.5% infections. In other words, the number of increased infections was 1 out of 100. There's 1 out of 100 more likely you already get an infection, but there's a 30% less likely chance that the hernia surgery will break down. So you got to do the numbers. Hey, 30% chance that it's going to be successful, 1% increase in infections, that's all. But he had looked on the web and it said 50% more infections. So immediately he thought, wow, the infection rate is high. So you've got to look at these things. Don't just pay attention to a percentage. Look at the numbers that are actually involved as you're reading about medical care. I think that's important. This is the first thing I want to discuss. So just hit me because these numbers, because now we have about 5 times as many people as we had initially. Now let me tell you something else that happened when I was in Wanakee 5 days ago. So a patient came in, wonderful patient, very nice, 88. She has post-herpetic neuralgia. How many of you have had chickenpox? Come on, everyone, raise your hands. Go on. Who hasn't? You haven't had chickenpox? I don't know. You may have had chickenpox. You may have had you may have had 1 or 2 pox. You could tell with that. How many of you had had the shingles vaccine? Raise your hand. Great group. Great group. You know, post-herpetic neuralgia is awful and it's common. If you had chickenpox, and 95% of you had, 95 to 99%. Remember there were chickenpox parties? I mean, we did that with our kids. Somebody had chickenpox and you brought them all over. You know, how wonderful is that? Let's give them all the disease. You wanted them to get over it. That's right. Chickenpox parties. Oh, what a strange life it is, you know. We could have COVID parties, but we don't. That'd be very strange. But anyway, let me get back to that. So a patient came in and she had post-herpetic neuralgia. So she had had shingles. Chickenpox virus is in your body right now if you've had chickenpox, laying dormant. And when your immunity goes down when you're older, the virus rears its head and will actually produce on one dermatome, it's called, one part of your, usually either in your eye, that's common, that's very serious, on the face, very common, but in the chest is most common, pain. She came in and she had chest pain, didn't know what it was, and she described it as going around here, half the body. It usually does not cross the midline because it's called in one dermatome, one ganglion. It's one nerve that it sits in, dermat. And I looked at her and talked to her she was there with her daughter. And I said, I think if you had a rash, sounds to me like it's shingles. And then the daughter, they had not told the nurse who brought her in, the medical assistant, that she had had shingles, like 4 years before. And I said, you have post-herpetic neuralgia. That's what I think this is. Very painful, wasn't able to sleep. So there's some medications you can give. Gabapentin, and another drug called pregabalin. And these are neurological medications that you can give that are very good. They're not opioids, they're not addictive, they don't cause constipation. They may make you a little sleepy, so they're good to take at nighttime, certainly for the first dose or two. And they're very effective for anyone with electrical pain from a disc or anything else. So I wrote out a prescription. Both drugs are generic. That's an important point of this story. Gabapentin is little older. These are anti-seizure drugs that work for neurological pain. And pregabalin or Lyrica. So I wrote out the prescription. Wait, and I sent it to the pharmacy. I sent it to Walgreens. And you know, the prescription was like initially the first day it would be once or twice a day. I wrote it out initially for 30 pills. And I know how much it should cost. If she paid cash, it would cost about $20, $25. Yeah, it was for 60 pills, twice a day. I got a call back from the daughter, and she said to my medical assistant, she went to Walgreens, it's going to cost $1,000. Well, I said, what are they talking about? So we laugh. But Walgreens wanted her to get the name brand Lyrica and spend $1,000. Now I have to tell you about a state law that has not yet fully been implemented. First of all, I ordered it, and the default is she should get the generic, which on goodrx.com, if you don't know that particular website, goodrx.com, you get a coupon at a pharmacy, may not be Walgreens. Walgreens does not use goodrx.com for many of their drugs. Other pharmacies do. CVS, Costco, Hy-Vee. You have to look and see what it is. It's a $20, $25. The pharmacist did not tell her that there is a generic equivalent that would cost her less. Because, among other things, if you don't ask, they don't tell. And part of it is actually a law that's still in the state of Wisconsin, where they can't tell you if it's cheaper to buy with cash than it is with your copay. Now, why does that law exist? You know what this means, right? So I had another patient, this is about a year ago, came in. He had been on antidepressant for many years, Zoloft, antidepressant, generic. It's a $4 a month drug at Walgreens, $10 for a 90-day supply. He gets his prescription at Walgreens. And he has marginal income. And I wrote a prescription. I said, I'm going to write it out for 90 days for Zoloft. And he said, could you do it 1 month at a time? I can't afford it. I said, why? Well, it's cost me $29 a month on my Medicare Part D. And I said, well, wait a minute, let's look it up on the on the Walmart. And I said, wait a minute, it's $10 at Walmart if you pay cash for a 90-day supply. He said, I've been going to Walmart for 4 or 5 years with that, and they never told me that. And I've been paying $29 a month for this prescription. And you meant I could get 90 days for $10 a month? Now, why am I telling you this? Because you have to be aware of it. If you don't take anything back from what I'm going to discuss today, is you have to be aware, among other things, of the pharmaceuticals that you are paying for. Every year you have to look at Medicare Part D and go to the website, or talk to a teenager to help you go to the website and look up whether or not you're on the right Part D for the drugs you're on, if you are especially on name brand drugs, because it changes. So 1 year, if you're on a drug like Eliquis, 1 year it may be Costco is cheaper, 1 year it may be CVS is cheaper. We're talking about $200 to $500, because that's a name brand drug. That is not a generic. 1 year it might be another pharmacy that's cheaper. So every year you go to the Medicare website when it's time to get Medicare Part D and determine whether or not you should have your drug sent to a different pharmacy or a mail order pharmacy, number one. Number two, when you have a copay on your drug, if it's above $10 or $20, say to the pharmacist, is it cheaper for me to pay for this in cash with goodrx.com? And they'll tell you. Now, once again, Walgreens does not use goodrx.com for many of their pharmaceuticals. Why? I have no idea. Well, I know why. Money, sorry. But pharmacies like Hy-Vee actually do it for most of them. But if you go to goodrx.com, look up your drug, find out how much it might be cheaper for you to buy it. My wife Penny was on a number of drugs, and 3 of the drugs it was cheaper for me to buy over the last 2 years by cash than it was to buy by our copay. But her name brand drug, it was better to buy by the copay. So I saved like $150 a year by just doing a little bit of that. And every dollar you save in this particular economic environment is a dollar earned. But I don't have to tell you that because you're all old people and you remember what life was like years ago. So I haven't even started yet, but I want to give you some tips. But let's start. You had a question.
Yes, it's a cholesterol question. Until I was in my early 80s, I had outstanding cholesterol. Mm-hmm. But now things aren't so as good. And there is a chart, and I'm not sure if it's the only one to use, which only goes up to the age of 80, which tells you what your degree of risk is. And so there's only an estimation for somebody that's older than 80. And so I have tried 3 statins, which I cannot have.
So we'll talk about that.
Okay, so that's an issue right there.
And is it worthwhile?
Yeah, yes, so yeah,
So-
okay, and so that's the question about that. So I am now on no statin. I understand from what I've read and also from the medical professionals that some of the drugs that you can take for cholesterol may lower the numbers, but they really don't have an impact on improving your situation.
That's right.
So I thought, well, why would I take something just to have pretty numbers? Okay, and so my first,
So let me answer this broadly.
and then I just have one more question after that.
Okay, well, let's do this, and then we'll do it. So she is not a plant, by the way. And the reason is I have an article that I pulled off to discuss with you that is embargoed until May 27th from the Annals of Internal Medicine. So I'm going to tell you this. It should stay in this room because it's embargoed. I can discuss it personally, but I can't discuss it media-wise on the air. That answers some of your question. It's really kind of interesting. It's an article I found very interesting. So the article has to do with older people taking statins. Then we'll talk about how you might be able to tolerate statins. Statins do more, by the way, than lower cholesterol. They actually reduce the inflammation in the coronary arteries and the arteries throughout the body and make it less likely you're going to have a heart attack and stroke. And you're right. The other drugs, with one exception, a drug called Zetia, Z-E-T-I-A, that's the name brand, but it's a generic, Stimby, does lower cholesterol and may, that's the word, the big thing is may have an effect on heart attacks and stroke. But statins, by and large, they do something besides lower the cholesterol. But I'll tell you how you might be able to tolerate a statin. But let me read you this article, because it's about it. So this was, statins are associated with a decreased risk of death from heart attack, even in very old adults. I mean, this is the study. I just pulled it down before I came here. So a study of people aged 60 years of older found that statin therapy in people 60 into their up to 85, well, let me tell you, the study started adults 60 years of age without any pre-existing coronary artery disease. Okay, so these were adults who didn't have a heart attack, they didn't have a stroke, and they were placed on statins between 2008 and 2015. Okay, so we've got good data. Patients they didn't have cancer, they didn't have other problems with their heart, they had no problems with their liver. And then they followed people. These were 80,000 people that they followed over time in Hong Kong to discover whether or not giving statins reduced the risk of heart attack and stroke. They found people in their 70s for sure, people in their 80s, and people as old as 85 had a reduction in heart attack and stroke on statins. So one of the questions that always comes up with statins is, wait a minute, maybe I should have been on it in my 40s and my 50s, but is it really going to do any good when I'm in my 80s? Well, if you're functional in your 80s, do you really want to have a heart attack or stroke? No, of course not. So this data comes on the heels of other data that have shown that statins are useful. Now, the formula that doctors use, PAs and nurse practitioners, is based on information from the Framingham Heart Study, which is a study in Framingham, Massachusetts, where we get a lot of our data, that has shown, just like this formula, that statins are useful as you get older. And the big issue in the formula is the older you get, the more likely you are to have a heart attack. And that's one of the things in the formula. So if I put your information in the formula and I make you 60, I don't think you're 60, right? Okay, you look 60. You may not require a statin, but at 70 you might look at it, and at 80 might be there. So the real issue is, do you get benefit from statins as you get older? And the formula shows it. And I think the data over the last 5 years has actually shown there is benefit. So I want to pull back for a second to high blood pressure. We know that you should always treat high blood pressure, no matter what your age is, right? We know as you get older, you're more likely to have high blood pressure. So why would you take a high blood pressure pill? Because you have faith, based on data, that it's going to prevent heart attacks and especially stroke. So the initial studies for blood pressure came out in the 1970s. There was a big study called the VA study. Before 1970, we didn't treat systolic blood pressure, that's the first number, well, we didn't treat diastolic blood pressure until it was over 100. So if you had a blood pressure of like 220 over 95, you weren't treated for blood pressure because nobody knew that it prevented stroke. And then in 1974, a big VA study of veterans showed that indeed you should treat high blood pressure to a lower number. And eventually, over time, over about a 20-year period, we discovered it's around 120 over 80 if you can tolerate it, maybe 125 over 85. But that wasn't there. So then the issue was you had to convince people they didn't have symptoms, they didn't have a problem, and you got to take a pill every day. You know what? That was not an easy sell. That took about a decade to sell people, especially older people. Older people go, I don't know about that. You know, first thing, by the way, if you want to see something cute on Saturday Night Live on YouTube, look at Saturday Night Live Alexa for Seniors. It's a very funny little two-minute video. But you know, you're older. It's like, you know, you've learned how to say, I don't know if this is going to work or that's going to work. It took about 10 years or more before people started taking high blood pressure pills. And still roughly 1/4 to 1/3 of the people with high blood pressure don't take any medicine and should take it. And about 40% of the people who have high blood pressure are not at goal because they don't want to take 2 pills or 3 pills. In other words, they don't want to actually put 3 things in their mouth every day. It's a very strange, when you think about it. I can keep from having a stroke by taking an extra little pill, you know, and these pills are all generic now. Most of the pills are generic, they're inexpensive. But I mention it because it's now going to be the same with statins. Why should we take statins when we're older, when we're 75, 80, or 85, when I haven't taken it when it's younger? And the answer is, the data right now shows it blocks the inflammation in the coronary arteries. You're less likely to have that. So you have 2 issues with cardiovascular disease. You have heart attacks and strokes. Many people are older say, you know, I've had a good life, and it's okay. I don't mind dying. I mean, people really say that it's okay. But nobody wants a stroke. Nobody. Nobody has ever said to me in my office, you know what, I don't care if I get a stroke. You don't say that, because you get a stroke, you're disabled, you're a burden to your loved ones, you can't do what you want to do, you may end up in assisted living or something like that. Statins reduce, along with blood pressure, dramatically the risk of stroke. We know that there has been an 80% reduction, 78% actually, reduction in stroke since I started medicine 40-some years ago, because of the treatment of high blood pressure, statins, less smoking, more exercise, whole bunch of things. But statins and high blood pressure medicine have been really the mainstays of the reduction in stroke and heart attack. Now, there are other drugs. Niacin will lower cholesterol, doesn't do squat, has side effects. There's some doctors that still use it. It's a worthless drug, except in certain circumstances. We have something called super high triglycerides. So niacin is worthless. Astimbi, the other drug, which is called Zidia, maybe has some value, so that can be useful. But there are some things you can do to tolerate statins. So there are basically, statins are a large group, but there are 2 different subgroups. One, Pravachol, which is a generic statin, is in one group. Lipitor and Crestor are in another group. They're sort of super statins. And sometimes if you change to a different statin from another group, you can tolerate it. Or if you take a super low dose of statin every other day, 3 days a week, it still has value. So a small dose every other day is what you should try to see if it makes a difference. So I had patients in my practice who were on very small doses of statins every other day, and you could see the measurement in cholesterol, and you could tolerate it. So my recommendation, if you would come to me, I'd say, let's go to this other group. You may not have tried Pravachol. Let's try the smallest dose, go every other day. And sometimes every other day after you're on it for a month or 2, you can tolerate every day, or sometimes you stay at every other day. So that's my... So any other questions before we go on? No other questions? Come on, you're old people. You always have questions. I'm an old person. I can say it now because I'm old. I can say that. But it's okay being old. We're all here. Yes?
I don't know how we define high blood pressure. When I go into the doctors, my blood pressure is like 160, 130. You know, it's definitely in the high range. But if I do relax and just sit and do the blood pressure test, either at home or in the doctor's office, it's in normal range. So do I have high blood pressure or don't I?
Well, first of all, blood pressure at home gives you a lot of good data, and that's your usual blood pressure. So I recommend the Omron electronic cuff, OMRON, good company. Get the $39.95 one. You can get the $65 one that keeps extra data, but you don't need that extra data. And you take the Omron blood pressure at home, you sit at home, measure it in one arm, measure it in the other arm, because one arm may be different than the other arm. When we're measuring blood pressure, the true way of measuring it would be to put a needle, which we don't do, in the artery and see what the pressure is. So this is called an indirect measurement. You measure it one arm or the other arm, and then assume the higher value is more likely to be normal. In reality, we don't really know which one. It's probably something in between. So at home, if your blood pressure is fine, but when you go into the office, your blood pressure is high, you may have something called white coat hypertension. It's going in the office, your blood pressure goes up, and your numbers at home, and a lot of people are shaking their heads because they have it. You know, even me, I'm in the office and I go, come on, relax, relax, relax. But I mean, really, at home, I don't have to relax. I mean, I am relaxed.
At home, I can get high blood pressure readings too.
Then you most likely have high blood pressure. If you're getting high blood pressure readings at home on a regular basis, other than a rare basis, then by definition of what we look at with high blood pressure, you have high blood pressure, which puts you at risk for stroke and heart attack. That's the only reason we care about it. And the answer is once you're over 50, 50% of the population needs one pill. Once you're over 70 or 75, most people need 2 pills. Because it turns out 2 pills in a lower dose is very effective and has fewer side effects than 1 pill in a super high dose. So it's 2 pills. Yep.
But I still have very low blood pressure at times at home, and the doctor that I was at said they were afraid of giving me blood pressure pills because I'd, get dizzy or.
Okay, well that's a very good question. So first of all, here it is. You've got a quandary. It looks like I have high blood pressure. I go to a doctor and they go, I'm worried it's going to be too low. Which, by the way, is actually a very important thing. So let me do a side of this. So if you have diabetes, I'm not going to ask how many people here have diabetes, but a number of people here do. There's something called the hemoglobin A1C, which is a measurement overall of your blood sugar for diabetes. If you're under the age of 65, the goal of that hemoglobin A1C is 7.0 or less. But about 5 years ago, maybe 7 years ago, Medicare recommendations changed that because too many people were having low blood sugar and then fainting, and then falling down, breaking their hip, and so on. So for people over the age of 65, it's not 7, it's 8. In other words, their blood sugar shouldn't be that low on medication. I mean, if you're not on any medication and it's low, that's fine. But if you have diabetes, you may push down that number too low because we worry about dizziness. So when it comes to high blood pressure, here it is. First of all, I don't know your whole case, so I don't want to talk about it individually. But if you've got high blood pressure, and if you were in my office and I said you've got some low numbers, if your number was like 95 over 65, it was really low, I wouldn't put you on anything, because that would be too low. I might drop it. But if your numbers at home are like 100 over 40 or 110, I might put you on a teeny tiny dose of a diuretic, because that'll give you hydrochlorothiazide, inexpensive, cheap. It's been around for 40 years. We know it has longevity. We know it has good data that shows that it works for stroke and heart attacks. And I might put you just on a little bit. And it may not change your pressure that much, but it may keep your pressure from going up at times that you become anxious or upset or you watch politics on TV. Which could all make us, no matter what tribe we're on, anxious and upset. But I might do something of that nature. But once again, I think it's worth a discussion with your provider. So if you were my patient, you would say, well, I want to know what the numbers are. I'd probably take it morning and evening for 2 weeks, see what the numbers are. So get some average and determine, do you really have high blood pressure, and it makes something. Once again, The educated patient is the best patient when it comes to that. Before I go on, another question? Yes?
Doesn't coffee
Pardon me?
doesn't coffee increase the blood pressure?
It depends on how much you drink. So here it is. Here's my coffee. So coffee can increase blood pressure if you're probably drinking a quart a day. I mean, a huge amount, not a small amount. Caffeine may increase the pressure. So one of the things, though, we know that naturally decreases blood pressure. Exercise, we know that. Exercise definitely decreases blood pressure. Eating a more Mediterranean diet, we know that. For many people, not all, reducing salt in the diet, that's a natural way that decreases blood pressure. We all eat too much salt, which mostly comes from prepared foods. If you go to Quick Trip over here, and they have wonderful food, as you know, prepared food at Quick Trip. It's sort of become a local grocery store. But look at the label and you see how much sodium it is in most of their food. We're supposed to get the equivalent of 1 teaspoon of salt a day at maximum. And if you go over that, that may be the cause of your high blood pressure. Reducing alcohol intake can reduce blood pressure. Weight loss can reduce blood pressure. So there are a lot of things, meditation and mindfulness. So there are a number of natural things that you can do to reduce blood pressure. And smoking, we know, is a risk factor for heart attack and stroke. And smoking, still 12 to 14% of Wisconsinites still smoke. And we don't know what vaping does. We're not sure. We don't know if vaping really is safer, than smoking. I'm going to make a little side before I go into another question. I'm talking about vaping. I want to talk a little bit about marijuana and seniors. Okay, I want to talk about it. So, first of all, as you know, in the state of Wisconsin, we can't get it for anyone with medical care because our legislature, in their supreme dumbness, has not joined 35 other legislatures that said you can do this for pain and discomfort. We continue to give opioids, hydrocodone, oxycodone, for pain and discomfort. They're constipating and they cause 100,000 deaths. Whereas a small gummy may actually work for your back pain, is not going to constipate you, and is not going to cause your death. So in their infinite stupidity, they won't take this up. And I find it irksome. I'm not talking about, whether or not we should take it up in, I think, 15 states as an inebriant like we do alcohol. I'm just talking about medical stuff. I'm just going to order to that. However, there's an article that just came out on the number of senior citizens who have ended up in the emergency room. It's like 5 times as many, and these are large numbers, because of marijuana. And the reason is they may have a younger person who says you've got chronic pain, and they give them a gummy which has 10 milligrams, we'll say, of THC in it. And it's way too much. And all of a sudden they can't move, and they end up in the emergency room. And then everyone is embarrassed to tell the ER doctor they took a gummy, and they end up getting a full workup for somebody who's having a stroke, which cost maybe $5,000, when in fact they had a gummy. The other issue is that people then, especially senior citizens, all of a sudden go home and eat the wrong brownies at their children's house and don't know it. So all of a sudden they go, I don't feel very good, and they've had 2 or 3 brownies. And some of them have actually caused catastrophic death. But the other is then they feel upset about it. So I think there's certain things you should pay attention to. First of all, if you have chronic pain and you want to try something for that chronic pain, and especially if you're on an opioid, head down to South Beloit, wait in line, or go down to Chicago where you can get it. And if you get a gummy, I think it usually has about 10 milligrams, you cut it in quarters and you try it when you're in bed before you go to sleep to see if you tolerate it. And you may end up tolerating it, it may not make you tired, and it may work for chronic pain. Unfortunately, the federal government, once again, in its infinite stupidity, has put marijuana in the same class as heroin. It's in the same class, it's a class 1. So it's the same class as heroin. So researchers have not been able to study it to see what it is, or if there's a subgroup of marijuana that may work for pain that doesn't inebriate you. Now, about 5 years ago, for 35 years, I did clinical research in our office. I did over 100 studies. I had a research coordinator, Brenda, from Belleville. We did a lot of research, wonderful research. And we did research about 5 years ago, well, maybe, 6 or 7 years ago, on 2 drugs for weight loss that were tetrahydrocannabinol blockers. In other words, they blocked THC receptors in the brain. Now, no one could be smoking around marijuana in the study. You had to say they wouldn't. But it blocked the receptors in the brain, because the receptors in the brain and the gut are very interesting. And we had people who lost 50 pounds on this drug. Rimonabant was one of the drugs that was BMY, Bristol Myers Squibb. And there were 2 other companies, Merck and Pfizer. And they lost a massive amount of weight. But the drugs never came to market because people had suicidal thoughts on the drug. In other words, it was very interesting, these receptors. So you block the receptor, and that blocked the desire to eat, but it also, for people who weren't depressed, we had to prove they weren't depressed, had suicidal thoughts. Very, very interesting. So the drugs never came to market. But I mention this because if you look back at the THC that's around, the marijuana that was around back when I was in college, and yes, I smoked, but I didn't inhale. And if you believe that, I'll tell you some other stories too. But the marijuana in those days, the marijuana that's present right now, I think is about 10 times as much or 20 times as much. So if you're going to try something like that, which you may decide, you have to be very, very careful. And if you're going to do it for chronic pain, you want to do it, you want to not smoke it, you actually want to absorb it. It absorbs differently and goes through your gut in a different way. That got me off it didn't get me off my topic. Another question, and then I'll go through. Yes?
In my lay research about various medications, I've come across something called the Beers criteria, which should be of interest to people in here because it looks specifically at the wisdom of certain drugs in the elderly.
That's right.
I wonder if it's a little bit confusing though, because
It's always confusing.
I see. So what I've done is I've asked the doctor, if I'm taking a statin, would I be better off with this than with that?
Well, first of all, so the Beer criteria, by the way, these questions are great, so I may never get to other things. So it doesn't matter, you're here to learn things. So the Beer criteria, it was a guy named Dr. Beer, B-E-E-R. It's not, I think that was his name, but it was his criteria of what drugs are safe in people over the age of 65. By the way, the reason why we use 65, it was really not defined until Medicare came in. And LBJ wanted to start Medicare at the age of 50. That was his real goal. But he had a compromise, and then it was like I don't know what the politics were, but 75, and they compromised on 65. But he actually wanted to bring it down to the age of 50, which would have really changed things, in medicine, because that's when a lot of people begin to use medical care. But that's where 65 came in, and as you know, 55, 65, 75, 85, those are really very different. Certainly 65 to 85, they're not in the same category on how you may respond to drugs. So drugs that are on the Beer list should be used with caution or not used in the elderly. So a good example of a drug that's on the Beer list is over-the-counter sleeping pills. Over-the-counter sleeping pills are antihistamines. They're Benadryl, basically. If you look at Tylenol PM, it's Benadryl, diphenhydramine. Or it's one of the other antihistamines that make you sleepy. I can't remember Sominex, but it's another. They're antihistamines. And antihistamines can make you a little bit dizzy as you get older. So in the middle of the night, if you have to get up and pee, may make you dizzy, you may fall. And your goal is not to fall. If you fall over the age of 65 and break your hip, there's a 50% chance you will be disabled in one or more activity of daily living, and a 25% chance you will be dead within 2 years if you fall and break your hip or your pelvis. Those are the data. So if you look at over-the-counter, as I said, over-the-counter sleeping pills, they're on the Beer criteria of not to use. Yet a lot of people use them, and they may use them in small doses, and it may not affect you at 65, it may not affect you at 75, but it may affect you at 85. So if you look up your medicines and you go to the Beer criteria, and you're on one of them, or you're taking the over-the-counter medicine, you have to think twice about it. Now, you all have access to a great resource besides your physician or nurse practitioner or anything. That's the pharmacist, And the pharmacists are really, really good. They can give you lots of good information, especially if you go in not at a time that they're harried and they're busy. And if you carry on a good, discussion with your pharmacist. By law, if you get a I don't know if it's by law, but it's certainly by habit. If you get a new drug, they'll say, do you know how to take it? then they'll discuss it. And they'll discuss it, as you know, in every pharmacy now. There'll be a part under HIPAA regulations where they have to consult with you on the drug. But if you have questions about your drugs, bring your list in and go to the pharmacist. Talk to them. Because they often, especially if it's not a busy time like 5 o'clock in the afternoon at Fish-Archie Road, they'll have the time to tell you what the effects are or the side effects, more often than your healthcare provider, which may not have the time or may. But anyway, so the beer, thank you very much for bringing that up. Yes?
I'd like to know if my blood pressure is forever low. What
Wait,
do I do?
what did you say?
If my blood pressure is forever low.
So your blood pressure may be low for a bunch of reasons. You don't need to be on blood pressure medicines. And sometimes we actually have to give you a medication to elevate your blood pressure, especially if you're dizzy and falling down. And this often actually has to do with something called mineral corticoids. So we produce glucocorticoids and mineral corticoids. They're produced by the adrenal gland. The glucocorticoids are things like steroids, prednisone, you've heard about them, testosterone. Well, that's a little bit different. But anyway, they produce one aspect. But the mineral corticoids basically regulate sodium and potassium in the body. And your blood pressure may be too low. And sometimes we put people on medication for that. There are many other reasons that your blood pressure, can be low. So. Yes?
Is there any drug that will treat without side effects osteoporosis?
On what?
Osteoporosis?
Osteoporosis.
Oh, osteoporosis. Okay. So as I said, we did clinical research in our office for years. And the first drug for osteoporosis was Fosmax. It was really the first drug. There were other drugs too, but the first effective drug. And in our office, like I said, we did lots of research. And I had to, the older women are generally taking this drug. It was for women. Men were not, there were no men in the study. It had to be women with proven osteoporosis on the densitometry exam, which is called the DEXA exam. So we had women who we were screening and who had osteoporosis. We're talking now about probably 20 years ago. We said, well, we have a drug that may reduce the risk of osteoporosis. And probably easily 8 or 9 out of 10 women said, I don't want to take a drug. I'll worry about it if I fall. It was very interesting. It was actually the hardest study I ever had to fill. Now, I know that women are more stubborn than men. Sorry. Sorry. Just making sure you're awake. But it was very hard to fill. And now, of course, women assume Fosamax and Reclast will do it. So what you want to do, first of all, it's not just the amount of calcium in your bone. The goal is you don't want to fall and break your hip. So let's look at that final common pathway. So first of all, how do you prevent osteoporosis? Part of it is genetic. If your mom had it or somebody else in your family, you're prone to have it. Part of it is smoking. We know smoking makes you more likely to have osteoporosis. If you're frail and not following enough of a diet to give yourself good muscle, getting enough protein, once again, it's risk of falling now here. If you don't exercise, you're more likely to fall. We know that exercise is strengthening exercise, a bit of aerobic exercise, and balance. Those are the 3 things you need for exercise. Once again, it's falling, that's the issue. If it's the wintertime and you're going out, when I go out, I put yak tracks, these things on the bottom of my shoes, so I'm less likely to fall. So it's falling that is the bottom line issue. So these drugs, the issue with the DEXA exam, so let me explain the exam. So the DEXA exam looks at how much calcium is in your bone. It's a very simple exam. Little thing goes across, and it tells you the density of the calcium in your bone. And the first DEXA tests were done by a guy, John Cameron, at the University of Wisconsin in Madison. When I was a student at the UW, he was doing initial research. He was a medical physics. He founded the medical physics group at the University of Wisconsin, where they were saying we should really measure the density of bone in a good way versus just looking at an X-ray and seeing osteoporosis. So he invented actually the first test, and that became Lunar, that then was bought out by GE, and a guy named Dick Mazies ran Lunar. So that was actually a Wisconsin-based group that did it. But the test is very, very iffy. So you have to be able to use, there are two companies that make it, GE and I can't remember the other company. And you can't compare the results of the two companies. So if you look at osteoporosis and it says you're on one, let's see, you get it, it says osteoporosis on Lunar, which is now GE. And 2 years later you get another test. You have to test on the same machine. Not the same exact machine, but the same company's machine. And you have to do it at a standardized lab. So if you do it, if there's one of the trucks that comes around and that says we're going to look at osteoporosis, the truck isn't very good. You know, you get these things in the mail, come and we'll test you on 20 different things for $200. Really? You think you're going to get the same test for $200 you get in your doctor's office? Really? Okay. You want to believe that? You can believe other things. So for osteoporosis, if you increase the density of your bone by 1 or 2%, you significantly reduce the risk of a fracture if you fall. But the goal is not to fall. So those are the only drugs that are in the class. They do have side effects. If you take Fosamax, you have to take it once a week on an empty stomach. You have to sit up. It can cause some GI distress. If you have something called Reclast, you get it. There are injections that you can get, and you only have to do it once or twice a year. I can't remember exactly which one. But they reduce it. But the goal is to keep from actually falling and breaking your hip. And that's where exercise comes in. How many of you do any exercise at all? Any walking exercise at all? Yeah, you're pretty good. But of course, you're the people who are coming in to listen to this, right? So you have a high percentage. But it's walking and exercise, so it's balance, you know, Tai Chi or dance or something else, you're just walking, it's balance. It's some sort of strengthening exercise. Recent research has shown, because women are less likely to do strengthening exercise than men, and recent research has shown that came out maybe, I think, 2 or 3 months ago, that it's very important for women to also engage in some strengthening exercise, even with 5-pound weights of some sort, that it's not just aerobics. So many women, especially younger women, who are, some of you are younger, I'm sorry, but some who are like in their 40s and 50s, and they do spinning and they just do aerobics, and they don't do any strengthening exercise with weights. And they looked at cardiovascular disease, heart attacks, strokes, and the development, and they found that you really need to do something with weights or with bands to build up your muscle strength. That's it. You know, you need, the other thing I want to mention with muscles is you need to have enough protein in your body, especially as you get older. And as you get older, your appetite changes. And it changes because you don't smell as good, which means, well, I don't mean you stink. I mean, you don't smell as good. I love English, you know. It's wonderful. If it's your second language, you really don't understand this sentence. You don't smell as good. And if you don't smell as well, you don't taste as well, because we do our tasting through our nose, actually. We only, through our tongue, we only taste salt, sweet, sugar, sour, and fullness called umami. Everything else goes through the nose. So as we don't taste as well, older people tend to like things that are sweet and cold, like ice cream. Now, everyone likes ice cream. I mean, little kids like ice cream. But as you get older, you tend to eat food that is saltier and sweeter and colder because you don't taste the other tastes nearly as much. So that's
salted caramel ice cream. That's perfect.
That's right. You got it. You know, I used to laugh. The 4 basic food groups are chocolate, sugar, starch, and grease, which means the chocolate-covered donut is the ideal food. It has chocolate, it has sugar, it has starch, and it has lots of grease. But getting back to it, so you need enough protein. So one way when you're older, and I've thought about this more and more, is to put into your diet, first of all, if we look at calcium, because you want to make sure you have enough calcium, it shouldn't just be from a pill. If you can, it should be from natural sources. So a container of yogurt has 450 to 500 milligrams of calcium. And the data shows once you drop below about 1,000 milligrams of calcium, that can be an issue when you're older. You don't really need 2,000, although the nutritionists or the dietitians will tell you. But it's really, it's probably 750 to 1,000 milligrams if you're less than that. So a container of yogurt appears to be absorbed differently than elemental calcium, which is what you get in a pill. So adding a little bit of yogurt to your diet, can be very useful. But I've been thinking about this more and more about protein and protein shakes. So have any of you ever heard of Costco? So, I have to tell you, I'm going to do a side story. My father died 26 years ago, and he liked to dabble in stocks. And about 2 years ago, I found a sheet of paper that I hadn't looked at. It showed a number of stocks that he owned. Now, when he died, he had a safety deposit box, which we older people often have. Yeah, none of my 4 children have one. And in the box, I found 5 certificates for stocks he owned. Remember, they used to be certificates. 3 of the companies went bankrupt, and the other 2 were worthless. So nothing was in there. But on the sheet of paper, it showed that he bought 100 shares of Costco Wholesale Club in 1987. And I thought, wow, maybe he's still on the record, and it wasn't in the box. You know, so it turns out there's a number, not a number, there's a website you can call. No, it turned out he had sold it. Those 100 shares today would be worth $20,000. He had some good ideas back then, but he sold it, so maybe they weren't that good. But anyway, at Costco, they have a protein shake, chocolate, and it's in vanilla, that is 30 grams of protein for 160 calories. So it's very cheap from a caloric point of view. Hershey candy bar is 210. All candy bars, Hershey's and Snickers are 210 calories. French fries, small fries at McDonald's, around 225 calories. Tuna sandwich at Sub, 6 inches, about 500 to 600 calories. I'm going to give you an idea. Big Mac is about 500 calories. So this is 160 calories with 60 grams of protein, 30 grams of protein, excuse me. I think adding protein shakes like that to your diet may be very useful because I think we tend to be more protein deficient as we get older. I think that may be more of an issue than we've given enough care for. And if you don't think you're getting enough protein, and the best protein, you know, if you look from an animal protein, obviously it's fish versus beef. Chicken is okay, but fish is really, the fat in fish is good. But you may want to look at that protein drink, to do that. That may reduce the risk of hip fracture because you may have more muscle mass because of protein. Once again, your goal is not to fall. That's what your goal is. Another question? Yes.
Should men be getting their bone mass scanned?
Men, the answer is it depends. So on the whole, the Medicare is not recommended. There's something called the U.S. Public Service Task Force, whatever the initials are, U.S. Public Service Task Force, USPTG or whatever it is. So they do recommendations on what has been proven scientifically, what hasn't been proven scientifically, and they do A, B, C, D, F flunking, which means that getting the test is worse than not getting the test. That's flunking. So when it comes for osteoporosis for women, they've given it an A and a B, somewhere between that recommendation. But for men, they've given it in special circumstances. And that's because men are less likely to have it, but they can have it, especially if they're on drugs, for instance, for prostate cancer, then they're more likely to have osteoporosis. But men have a more dense skeleton, and so they're less likely to fall and have it. On the other end, if they're frail and they smoke cigarettes, then they're more likely to have it. The other issue is, while we're on the male issue, so there's something called aortic aneurysm, and if you get it and you don't know about it, you can bleed and you can die. And some people are shaking their head because they either know somebody who died suddenly from it or they've needed surgery. So aortic aneurysms you screen it one time with an ultrasound for anyone who has smoked 100 cigarettes in their lifetime. Isn't that astounding? That 100 cigarettes over your entire life can make you at risk for having an aortic aneurysm. It shows you, I'm sort of shocked by that number, how toxic tobacco is. I mean, 100 cigarettes are not a lot of cigarettes. I mean, I smoked when I was in college because I thought it was the best way to attract women. So, of course, I inevitably married my wife Penny of 50 years, and she didn't smoke, so it didn't work. But anyway, but 100 cigarettes, and then you may have an aortic aneurysm. So it's especially true. It's actually more likely to happen. The men are the ones who are screened. So getting back to your answer is, in certain circumstances we screen, in other ones we don't. Another question? Yep.
My bone density was a negative 2.9.
Pardon me? What?
My
Your bone density
was a negative 2.9. And they refused to give me medication that boosts up the osteoblasts because I was on Fosmax and I get infused with Reclass.
With Reclass.
But then you're left with bone, but it's kind of crappy bone.
Well, it's a good point. No, it is a good point. So we give drugs for osteoporosis, Reclass and others, for 5 years, because after 5 years, it's been shown. There's some seats over here if you'd like. Yep. After 5 years, it's been shown that it doesn't do any good, and you may get bone that is more spongy and not protect you. Like you say, it's not good bone. It's different bone. So it all depends on the structure of the bone. It's not just bone, but it's structure of bone. So it can be complicated in cases such as yours, where we really don't have a good way of. Once again, we don't have a good way of necessarily producing more bone.
I'll give it to you when you're -3.
So you've never been on the medication at all?
No, I've been on,
You've been on the medication.
Fosmax a long time ago, and then now they infused me with Reclast, but then it just stops the osteoclast from breaking down the bone, but they won't give me the stuff that creates.
So we'll talk about it. Come on up afterwards and we'll talk about that individually. Yes?
So is there a good alternative to Tylenol PM?
Well, that's a good question, isn't it? That's a real problem. How many of you don't sleep like a baby every night? Now, think about how babies sleep, though. I mean, I have 7 grandchildren, and when they're babies, they don't really sleep very well. They wake up throughout the night. Sleeping like a baby is kind of a funny thing. Is there a safe drug to give for an older person to sleep? And the answer is there's some difficult drugs. So the prescription drug, gabapentin, which I talked about for neuropathic pain, can be a very useful drug, which is not on the Beers list, that can help people sleep. So it's good. We know that regular sleeping pills, sleeping pills that we give in the short run are not good, because you can become habituated to ones in a group called benzodiazepines. You can become habituated to those pills, and then over time they don't work as well. The only over-the-counter regular pills are basically antihistamines, so they meet the Beer criteria. So you have to look and say, am I going to get too weak or not too weak? And so a lot of people take them, and they take them okay. The Beer's criteria is a little bit conservative. But, one of the things I tell people, if you're going to take Tylenol PM, if you get up during the night, sit at the side of the bed and count to 20 before you stand up. Yes, you are going to wake up more. That's the goal. So you can wake up more. And if you make sure that it's safe between where you're starting and where you're going to the bathroom. Make sure that it's well lit. Make sure there are not throw rugs around. And if you feel unsteady, take a walker. You can get a walker, senior center, they rent them out or buy one. So when you get up during the middle of the night, you may not need a walker, but you may feel unsteady. Use a walker to go bathroom, because what you want to do is you don't want to fall. So there are other things you can do to reduce the risk. But we all take risks. We take risks when we get in the car and we go down Fish Hatchery Road at night. We take risks when we drive a car. So, when you're on this pill, you are taking a risk. There's no drug you can possibly take that does not take risk. Because look at Tylenol. We used to think Tylenol had no risk at all. Well, Tylenol in alcoholics in large doses causes liver failure. We didn't know that. But we're talking about alcoholics. I had a friend of mine, distant friend, and he died of liver failure. This is back 30 years ago, before it was really known, because he was an alcoholic and he had headaches, and he was taking, like 1,000 milligrams of Tylenol 8 or 9 times a day. So he was taking 8,000 milligrams of Tylenol. Didn't work for his headache, caused liver failure, which he died from. We're talking about back in the early 80s, where we didn't understand that. But he had other issues, but he was a young guy, so he had alcoholism. He had alcohol use disorder, and he was taking Tylenol, so the risk came. You can take up to 4,000 milligrams of acetaminophen if you're not drinking any alcohol. If you're having probably more than 1 drink a day, you should lower that number to probably 2,000 milligrams at most. That's good. And I'll take another question. I will get through these the next time I'm here, by the way. But these are good questions.
You didn't mention melatonin for sleep.
Melatonin over the counter, you could try. That's right, it's good. So if you're going to get melatonin, let me explain just a little bit in the last few minutes that we have. If you're going to get a drug that is not regulated, so the FDA regulates vitamins. If you go and you get a vitamin tablet like Centrum, it's regulated by the feds, and they have to prove the vitamins are in there. But complementary and alternative medicine is not regulated by the feds at all. And there are many reasons politically, but also some other reasons. It would take a lot to actually show that the drugs are really in there. And the complementary medicine lobby said, we don't think we should be regulated, which is okay. There should be on the label that says, not certified or not regulated, because you wonder that when you go in and you look at the label and it says like Nature's Way melatonin, and you wonder what it is. So let's say you want to get melatonin, which can be good. So there's a website that I like called consumerlab.com. And it costs $25 a year to go to that particular website. But they test all complementary drugs and to see whether or not they have it. So if you're buying the melatonin, in some cases, the melatonin that you have may not be, well, wait a second till that's okay. We've all suffered from that. It's all right. It's all right. We've all been there, believe me. Everyone in this room has had their phone ring at an inopportune moment. What'd you say?
That's a medication reminder.
Hey, not bad, see? So in some cases when you buy melatonin, there's nothing in there. Or it might say 10 milligrams, but there are 50 milligrams, or there's 2 milligrams. So there are two ways if you're looking at melatonin. Number one, I look at the house brand and I say they're going to stand behind it. So if you buy Costco, CVS, Target, Walgreens melatonin, they're going to test it. That's my thought, because they don't want to all of a sudden have somebody test their melatonin, find out there's nothing in there. So if you buy a house brand of a large pharmaceutical company, you're likely to get the drug you're looking for. The other way is to go to consumerlab.com and look at what they say, and then look at the cost per milligram of melatonin. Because the cost from the most expensive brand to the most inexpensive brand can be a 10 times difference. Can be a big difference between them. But melatonin, for instance, at Costco, is, I look at Costco, they're going to stand behind it. They're Kirkland brand. They're really looking to make sure they keep a high quality. If I'm going to get melatonin, I'm going to buy their brand, and I'm going to assume that it's good. And I would do that. So you've got to look at the brand when you're actually buying it. So I'll answer one more question. Or wait, I haven't called on you yet.
Okay, yes. So getting back to the food is medicine, but if you see so many patients, I'm thinking you must recommend some type of supplements that we can check out with Consumer Lab.
Well,
I just bought glucosamine, for example.
So the only supplements that I recommend, first of all, I go back and forth on a multivitamin, and I'm now back on a multivitamin. I think part of the problem is people think they don't have to eat well because they take a multivitamin. So that's the issue. And I have one that I chew. I don't like swallowing the big pills. So I get, at Costco, I get a multivitamin, a gummy multivitamin, not a marijuana multivitamin, a gummy multivitamin. Calcium, I have a container of yogurt every day, and then I also take a calcium pill. I take myself. So I think it's 500 or 750. Once again, it's a chewable one. It's like candy. It's 5 calories, so I like that better than swallowing the big pill. I take vitamin D. I take 2,000 milligrams a day of vitamin D. That's it. I don't take anything else.
No fish oil.
Well, fish oil is plus minus. We know that eating more fish is good for you. Roughly 25 to 30% of Americans take fish oil. Now, the data and the reduction of heart attacks and stroke really comes from the Mediterranean diet, where they had fatty fish like salmon, that has it. But it shows that fish that are fatty are good. But there's a difference between fish and fish oil. Bite into a fish oil capsule, it's different than eating a delicious piece of salmon. So eating fish twice a week, I think, is better. No, fish oil has not had good data. It does show that it reduces triglycerides in the bloodstream, but it's a cosmetic reduction. It has not been shown to reduce heart attack and stroke. So your numbers are better, but it's a reduced heart attack and stroke. So I don't do it. But if you take fish oil, especially if you burp and you don't like the taste of fish in your mouth, put it in the freezer and take it at nighttime, and you're not as likely to smell. So we've reached 2 o'clock, and I didn't get to anything, but I think we answered some good questions. And we'll do this again in a few months if you'd like. So, thank you. Thank you very much.